Oh, yes, continue. Sure, record away. One of these days, I'm going to worry about my recordings being out in the world. But right now,
I know. I think of the same thing.
it's like if somebody really wants to find me, they can find me. All right, so I don't know. I think everybody finished at 1:30 with their last class or last group or whatever you want to call it, seminar, meeting. So maybe give them another minute or so, and then I'll start. Just because I know that you and I both have about the same amount of slides, Joyce, and
I have a few, so just 30 minutes for each of us. I was going to do like 20, 25 minutes, and that way we can have
a few minutes of questions. Yeah. Okay, that sounds good.
You know, why don't we do that, Lisa? Why don't you do about like 20 minutes? I'll do about 20 minutes, and then we can have discussion after
a little bit of time. Okay. All righty. Well, then I'll probably just go ahead and start because we don't want to run out of time. So I should introduce myself. So I am Lisa D'Angelo. I'm a professor in the Communication Sciences and Disorders Department. I am also a speech pathologist and have been for 32 years. And I've worked with brain injuries, veterans. I work with all ages, so I'm kind of a weird one, but I love especially, this is where all my research is and where most of my day is spent is working with people with brain injuries. So that's what I'm going to be talking about. And then Mikal-Flynn is going to be talking, Dr. Joyce Mikal-Flynn will be talking, connecting the recovery and the process of post-traumatic growth as well. So we're going to go through kind of the nuts and bolts of brain injuries a little bit, just because I'm not sure what the background is with everybody on their experience with brain injuries. There's, a definition of brain injuries. It could result from a loss of oxygen. It could result from a fall. It could result from toxin exposure. Acquired brain injuries is a term that we use frequently because traumatic indicates that there was some kind of trauma, but sometimes a brain injury occurs other ways. And we're talking about veterans today. So usually when we're talking about veterans, we're talking about trauma. Although there have been, other things like toxins, et cetera. Hypoxia is always possible in any setting. So causes of brain injury usually falls, recreational things like sports, motor vehicle accidents, violence, war, training for war. Those are all places where people can get brain injuries more likely. We do have an increase in brain injuries in our country. We have an increase in brain injuries throughout the world. And people are surviving longer because we have better medical care. It used to be in World War II, people were left, or World War I for sure, people were left on the field. World War II, people were able to be saved to some degree, and we've gotten better and better at recovering or helping people medically, and then the recovery process is much more well understood. So veterans and TBI, this is a direct connection. And this is just a direct quote from an article a few years ago that they looked at over 350,000 military people serving in the military, and about 17.3 met the criteria for TBI. And about half of those reporting multiple TBIs. And that's unusual because reporting is a big question. And there's also a direct connection between PTSD, depression, back pain, suicide, and substance abuse with this population. Most commonly now, in the old days, it was actual, being hit by a bullet or being shot. And now it's more commonly that people are going to have suffered blast injuries. And a blast injury doesn't even necessarily mean that you feel or you have some physical response to the blast. You might not even have any physical injuries, but just being in the presence of a blast can be a traumatic brain injury cause. So we have in fact, when I ask the question of the veterans that I work with, I'll say, well, did you have a brain injury? Yes. How many did you have? Or when did you have it? Which one? That's what I get, which one? Because to them, this is a common occurrence. Now they talk about it. There's a little bit more openness about talking about it because the VA and the military has made it about face, and now they are responding to this, and they are actually doing more research, and they are paying for services for the vets, because in the past, there was a period of time where people were told in the military that that was just post-traumatic stress. You didn't really have a brain injury. You seem fine, because many people are the walking wounded. So we do know that civilian research with TBI survivors in the military has been linked to suicide, lower quality of life, and mood and anxiety disorders. These are some more statistics, but they're very helpful in understanding this population. Military personnel are more likely to have mild traumatic brain injuries, but there are quite a few moderate and severe as well. And mild traumatic brain injuries used to be kind of considered, you got your bell rung, no big deal. And that we understand now much more that mild traumatic brain injuries can sometimes be just as bad as a moderate brain injury. And the long-term sequelae can still be long-term. It's not necessarily that you're just going to be better in a few weeks. Most people get better in a few weeks with a concussion, but there is 10 to 30% of that group that will have persistent long-term issues after the concussion. And sometimes it's just a misdiagnosis. They were told they had a concussion, but they really had a pretty significant brain injury. So the incidence has dramatically increased of traumatic brain injury. Many people are reporting from Iraq that experience. 43.9% of those who reported a TBI also reported a loss of consciousness and post-traumatic stress. Blast injuries is a whole other, we could talk for hours about blast injuries. This is more common these days in our military experiences, in people's military experiences. It depends on how far away they are from the explosive. Are they in the explosive? Are they near the explosive? How their body was facing? And they could have other injuries. They could have other injuries on their body. They actually frequently have hearing loss because they actually lose hearing in the blast. You can also have blast injuries that are not even induced from a bomb. And we've had some of these occur in our embassies abroad where people are being exposed to kind of blast type frequencies, and that is causing brain injuries in our embassy workers. So that's a whole other discussion. But Veterans Affairs, VA is finally acknowledging that they're 36% reporting TBI connected with blast exposure, and 44% had blast and non-blast. And I worked in the VA as my first year of experience as a speech pathologist. And so I saw this up front. I actually worked in the brain injury rehab unit before we got into the Middle East in this last 30 years, I guess, or 25 years. So these are just some slides relating to the military and brain injuries and kind of the experience. There are some real important points relating to veterans and TBI. There's that feeling of, I don't want to report things sometimes because it's honor, it's leaving your team, it's, not wanting to cause a problem or, not wanting to complain and, being part of the group, being part of the platoon. And, that is really a big concern because there's very much like, not reporting is a common aspect. And then it's not really, did you have a TBI? It's more like, how many did you have? And then PTSD and concussions can sometimes be hard to tell apart. Brain injuries and PTSD sometimes share a lot of the similar experiences, similar problems. And sometimes there's premorbid issues that relate to that as well. Like people with learning disabilities or have ADD are more likely to have a brain injury and are more likely to have gone into the military. So there's all these premorbid mix of things, maybe other kind of addictive personality things, risk taking. So there's premorbid issues that are connected with this as well, not always. And many times when people come back from the military or come back from serving, they go back to school, they go into maybe a new career, they come back to their family. And so there's all kinds of things that could be impacted by their possibility of brain injuries, like going back to school. And brain injuries do impact your cognitive function. Mm-hmm. And so those issues can be, and I just realized that I cut out that whole slide, but your cognitive function could be affecting your ability to go back to school and work. And even things that seemingly were easy before are very, very difficult after a brain injury. And you could be like the walking wounded. You look fine. You look great. That's actually a title for a book written by somebody who had a brain injury. You look great, because that's what everybody told her. And blast injuries, like I said, are very common and not always reported because people don't realize that maybe they had an injury that was related to a blast that they were close to or had some experience with. Just some more pictures. That's the VA at Mather. I worked at the VA. There's a lot of services that are available. Of course, there are more services available in the VA, but there's a ton outside of the VA as well relating to brain injuries. I'm going to talk a little bit more about that and what it looks like. I wanted to put in here about concussion because that is a misunderstood term. Mild traumatic brain injury, concussion, so many more, and people are understanding it more, of course, because of the NFL and chronic traumatic encephalopathy. The movie Concussion, if you haven't seen it, it's a good movie. We are understanding a lot more about concussion, and we also want to really work on this more or help people with this. So there's quite a bit of research going on right now to see if we can help those people that still have prolonged experiences after this, military or not. There's Dr. Omalo, who's the scientist who first discovered CTE. This is Junior Seau. For those of you who don't know the story, Junior was a very talented football player who had multiple concussions throughout his career. He started playing when he was 5, and he took his own life because of the fallout from his multiple brain injuries. This is getting into, I wanted to give you guys the framework for the brain because we're going to talk about the brain and addiction, et cetera. But the brain really is impacted. Even if there's not an overt sign of a brain injury, you can have dramatic impact inside the cranium. So there are mechanical processes occurring and neurochemical processes occurring, and there is prolonged events after the brain injury. Your brain is actually trying to fix or trying to repair after the brain injury. And so there's a period of time where there's loss of tissue, there's cell death, secondary cell death, and there are neurochemical changes that actually are in response to the injury, but actually create more problems sometimes. So this is just an overview of that. You can actually see that there's stretching and tearing and shearing because the brain is like a piece of Jello inside a very bony case. And when you move that Jello, whatever way you move it, or it's impacted in some way by a blast or an actual blunt strike, then that can affect the movement of the brain. And then that movement can actually be tearing and shearing and injuries, bleeding in the brain relating to that movement. So we know that about the axons, that there's swelling. We know there's disconnection. We know that there's diffuse injury that you might not even be able to see on an MRI, depending on how intense the brain injury was. And it might be very diffuse. It might be like little teeny points throughout the brain. There's a lot of neurochemical activity with calcium and phosphorus and potassium, lots of kind of overwhelming response, which sometimes can actually create its own problems. You can have microhemorrhaging in the brain. You've got this issue with the sodium and the ion flux, which is out of whack. And so your brain is not functioning normally. And then the glial cells come in and try to repair. So there's a lot of things happening microscopically in the brain with a brain injury, whether it's mild to severe. The neurological process, I like this slide because it kind of breaks it down a little bit. It could be at the molecular level. There could be changes in the cell membranes. You can have ion transport issues between cells, mitochondrial dysfunction, which in itself can be an indicator for neurological disorders if your mitochondria is not functioning normally because of glucose uptake, and there's all kinds of dysregulation occurring at this point. And then hypoperfusion, there's not enough blood and the glial cells are overwhelming. So there's all this disorganized response. It is a response, which is good because the brain is trying to help and repair, but it also is a continuing process that's going on days and weeks after the brain injury. And then the shearing I talked about, the actual tearing of axons between the cells. So this is another view of that, another overview. I'm happy to share my slides. I will send anybody my slides. If you want my slides, feel free, let me know, and I can put up my email afterwards. But their primary injury is one thing, but then there are further injuries afterwards is the most important takeaway from this, and further cell death and axonal degeneration and synaptic dysfunction. I'm going to talk about synapses later. So this is the neurological process with pictures as well. Swelling, pressure. Anytime you have pressure, you have to really, seriously, you have to put a hole in the brain to release the pressure. Otherwise, you will have more injury from excessive pressure. There's no room to go in the cranium. So they will actually put a bolt in to relieve pressure if they need to reduce that and take out the swelling or take out the fluid or take out the bleeding on the brain if needed. And that is more of a neurosurgical process that would occur early on after a brain injury. But sometimes this is not even something that's obvious. This is an example of mild TBI on this side. You can kind of see that there's a little teeny brain injury here. And I think I have a couple more that show, the one up here on the right is more advanced after many mild TBI. Severe, you can see here, this is a more severe. You can see this is very throughout the brain here. And there's multiple points of injury. This is just really obvious, of course, the one on the bottom. The one up here on the left is a normal brain. You can see how close together those sections are and how it's very compact. Whereas if you look at the CTE brain, you could see that you actually lose a lot of structure, you lose a lot of tissue, you actually have shrinking of the brain. And there is really similar processes to what it looks like with Alzheimer's. Actually, it looks very similar to Alzheimer's. And you can also see, I'm going to put you guys back up here. You can also see on this one, this is a more severe brain injury. This is another example. This is actually kind of looking at these little tiny little punctate hemorrhages. So this would be a more mild brain injury, but you actually see and these are injuries here too, these little white points. You can actually see holes in the brain. And that is cell death. And it could show up as behaviors or difficulties. So what about after? What can we do? And I didn't put in the slide, I should have, I didn't put in the slide about differences, about what things are different after a brain injury when it comes to cognitive communication skills, because I was so focused on the overview of TBI. But we can work on all this stuff. So we can work with physical therapy. We can work with speech pathologists. We can work with occupational therapists. We can work with nursing and the doctors and counselors and psychologists and neuropsychologists. We can work with people after they have an injury. And we deal with the medical stability first, but then we get right in there and we assess and we look at all the function, whether it's communication, movement, self-care, independence, counseling, mental health support. We can work with all of that after a brain injury. And we are brought in right away. I meet the helicopter on top of the hospital sometimes. That's how early we get in. And so we can make a difference. It's not like it's like you have this and you're done. So the rehabilitation team is really what we do afterwards. These are all this is not exhaustive. We have many members of the team that probably aren't even on here, many different physicians that could be involved, nursing, speech pathology, physical therapy, social worker, occupational therapy, neuropsych, clinical psychologist, vocational rehab afterwards. CBT, cognitive behavioral therapy, is a very successful approach for many of these problems with regard to mental health and emotional issues after. This is a trauma. Any brain injury, whether it's from being a veteran or being in a car accident, it's a trauma. It's post-traumatic stress, regardless. It's a major thing in their life. So the whole team is viewing that in that perspective. Now, I want to bring this up now, and I'm going to come back to it. Everything that I do as a speech pathologist, everything we do in rehabilitation is based on, and actually habilitation, because I work with kids as well. I work in the schools, I work in a hospital, I work in the schools, and I work at the university primarily. Not because just because I love it all. I really can't get away from it all because I love it. I love working with my people. But neuroplasticity is really the basis of what we do. When we're working with kids, we are providing them with stimulation to stimulate the connection in their brain, and then we're reinforcing that connection in their brain. And then we are increasing that use of that ability. So you really have to have stimulation. It's experience dependent. Your brain can make connections, and then we reinforce those connections with use, with actual functional abilities. So neuroplasticity, this is something you could see. You can actually look now for research that shows a brain before therapy, a brain after therapy, and you could see the activity levels in the brain change, increase, change locations by the act of having therapy. It's amazing because we used to know it by behavior. Now we can actually see it neuroimaging wise. So I will come back to this point because Joyce is going to talk about this as well. The process, of course, like I said, for TBI is you go through the whole medical process. If you don't go into medical because you look fine and you had a mild brain injury and you didn't even know you had a brain injury, that's a whole discussion too. And that sometimes takes longer to get to the point where they're getting help. Hopefully they will get help. They usually find me, or the people around here are finding me now through the research that I'm doing, mostly by word of mouth, but hopefully that will change with public awareness as we try to get the word out. Acute medical care, rehab comes after acute medical care. You might go to a subacute or a SNF after being in the hospital just to get strong, build up your endurance, home and outpatient, and then return to life. That's our goal, right? Get you back to your life. The steps involve assessment, therapy. We work in a structured, hierarchical manner, gradual increase in independence, support, education, collaboration. It's a team. It's always a team. Team with your family, team with your specialist, team with the military. It's a team. So speech pathology, these are just some pictures of some of the things that we do in rehabilitation with traumatic brain injury. Occupational therapy, wonderful work with some, activities of daily living is the best word to put there. And then physical therapy is probably the most understood of all the therapies, right? Because it's easier to see. And then community resources. This is where we're really lacking. This is the part where it kind of is really difficult. And that's where I think Joyce and I and our partner, Brian, we are working really hard to build up some more of this community resources for brain injuries and in our community. We'll start here. There's not a lot out there. Pretty much after you go to rehab, after you have outpatient, that's it. And your insurance can say, we're only going to give you 8 sessions. Or, the military is different because if you're service connected, you are served. But there will come a point where you might not get any more therapy, regardless of what institution you're working or going through. So there are some community reentry programs. Some programs are supported by grants, Medicare, Medi-Cal funds. We have a TBI advisory board. I'm actually on a regional board of network providers, but there is a TBI board for the state of California, which is overseeing we're trying to collect a database, and we're also trying to connect everybody so everybody's not trying to reinvent the wheel. There's a big hole in our system on how to deal with TBI. It's not really well understood by public yet. Families and survivors are struggling because, I have patients who they are sitting home all day long in their wheelchair waiting for their family to come home so they can get taken to somewhere because they can't work right now. They can't go back to school. There's no services after a certain point. Long-term issues. Some patients are treated like they're psychiatric patients. They get prescribed some pretty heavy-duty drugs because they're reporting things that sound like psychiatric issues. And sometimes they are misdiagnosed and given drugs that actually have sometimes an unintended effect because the drugs can impact them differentially because of the brain injury differences in neurochemical metabolism. And so that correlates with those new or continuing issues with substance abuse, behavior, social interaction, isolation. All of these issues are kind of all connected. And it's a concern. It's a concern. Alcohol and substance abuse after TBI is well documented. Sometimes they did it before and now they're doing it afterwards. So that is just a continuing pattern. A lot of the mental health issues are not resolved or are coexisting or confounded. We know that differential alcohol effect on the brain after a brain injury, it actually increases the swelling in the brain. They're more likely to have another brain injury. They have poorer outcomes in their recovery if they're using alcohol afterwards, and it can impair their recovery. We also know medications can actually have the opposite effect of what they're intended. So I've actually had patients of mine who had brain injuries and they were given certain medications to help them with sleep or headaches, and they actually made them more confused, more hallucinations, more difficulty, more headaches, extreme sensitivity. So exactly the opposite of what they were trying to do. Animal models and addiction, TBI and addiction. There's a lot of research on this because a lot of our TBI survivors, military survivors of TBI have had addiction issues, and the VA has done a lot of research on this. Animal models are really what they're studying more, but they are pretty closely related in behaviors that we're looking at. So they're good models for this. There's several pieces of research that I just pulled in here, but we have seen that with TBI, with brain injuries, and this is animal models, there is a change in blood-brain function. So the blood-brain barrier, changes in the neuronal networks and the way the synaptic areas, the synaptic function within certain areas of the brain. So that is related to the perception of reward, which we know has something to do with addiction. One study with rats that had either mild or severe injuries, they actually had increased neuroinflammation, and that was a direct predictor of their development of addiction to cocaine in this study. Yeah, I think I heard somebody. Same results were also seen with oxycodone, because a rat study where they were given one single blast exposure, they were more likely to be addicted to oxycodone. So there's some research there, and more needs to be done, obviously, so that we can work with this and help with this problem, because it's a long-term problem. Neuroplasticity, like I said, we'll come back to this. Joyce is going to touch on this. And this is what I really wanted to put out there about neuroplasticity. And this is really important for us talking today about all of these issues with addiction and recovery and mental health issues, that neuroplasticity is real. And this is something that's well documented. We have good evidence-based research for this. Your brain is primed for learning, no matter what. Your brain is ready to learn. You have to have experience to learn. And then you need to make those, your brain is making connections when you learn something new. And those connections have to be reinforced. That's how you know that you've learned something. You don't just learn a letter and then learn how to read. There's a whole lot of practice that goes in that process before you're able to read. Same thing with anything we learn for our brain. Either it's habilitation or rehabilitation. It has to be reinforced, and that helps us go on to learn more things as well. So in that line, I'm going to stop right there. I think I did okay on time. Post-traumatic growth. This is where Joyce comes in, and she always lifts me up whenever I hear her talk, because this is just so empowering. And I love her broken arm analogy. I put it in there. I don't know if she's going to talk about it. Maybe she can touch on it briefly, because it's one of my favorite things. I use it all the time. I stole it. Sorry, Joyce. But she's going to talk to you about the anatomy of well, she's going to talk to you about all of her work. So I'm happy to introduce Dr. Joyce Mikal-Flynn.
So that's awesome. I just want to make sure I can share my screen here.
I think we can stop the share. And
then let me go to mine. Hold on one second. I thought I had it all together, but 1 second. I'll make this put together. Okay, do this.
And I just put my email in the chat room for those who, I know at least one person reached out about slides. I'm happy. I'll share anything.
Okay, let me do a Zoom meeting and see if I can get back to what I want to do with mine.
I think I have yours too, if you have trouble pulling it up.
Oh, I have it right here. Right here. Okay, so I'm going to go all the way to the front. Okay.
It's a good thing we've been Zooming for a while now.
Yeah,
now we're becoming, yes.
So first of all, I just want to say how spot on, obviously, Lisa is about all this. And I'm going to just follow up with some of the aspects that I've been working on, which is trauma care in general. But I do touch on TBI, ABI, and addiction dependency, but from the perspective of post-traumatic growth, resilience building, and using these incidences as powerful vehicles for growth and development. So I have done work on the individual survivor, the secondary and vicarious survivors, as well as community surviving. I was in Oklahoma City, and this was the site where the truck, it was a street where the truck was on where the bombing occurred, and they didn't rebuild on that street. Instead, they put a reflection pool, and you can see where people in their lives go through things. And they, at one end of the street, it says 901, and the other end of the street, they have 903. So within this 2 minutes, lives changed dramatically. And now you have to figure out how to do things. And so one of my favorites I use is Viktor Frankl. And I want us to think about between stimulus response, there is a space. And in that space, and this is so critical when we're talking about people, their power to choose a response. And in that choice is where their growth and their freedom lie. So I will talk just briefly. I have a personal experience with this, and Lisa talked about there's a variety of ways that you can get a TBI. Mine was through anoxia or oxygen deprivation. This is a picture of my family in December of 1989. In July 22nd of 1990, I was in a swim event, kind of a long story I'm not going to get into. You can read more about that with other things I have, but I swam the last length of a relay. I don't know, I don't remember any of this, but I got to the side of the pool and something happened and I sunk to the bottom of this pool that was 13 feet deep. My husband dove in, got me to the side, and luckily there were a lot of people around who knew how to do CPR. And I had 22 minutes of CPR poolside. I was 35 years old at that time, and so I had to come back from that. I survived that. But the toughest part of that survival was the brain injury. And when you're talking about not reporting or whatever, I basically am telling you right now, there's probably nothing scarier than walking around knowing you're messed up, but you're so afraid to tell it, or you don't know, am I the only one or whatever. But this event led to the work and the research that I've been doing literally for the last 3 decades. So when we, and also I just want to go back really quick and a thumbs up for all the speech therapists and the OT therapists and everything, because that is what got me back and going. But it was interesting. Nobody did that for me. I had to eventually ask for that help. So I look at post-traumatic growth, and I'll throw this out just so you can think about, what do you know about post-traumatic growth? Have you ever heard about PTG? What do we do to promote and support the positive in the aftermath of trauma? How do we look at that? And so I'm looking at TBI and addiction dependency, but it's really something I want us to think about. Post-traumatic growth came from the work of Tedeschi and Calhoun. And they started talking about, their psychologists at University of North Carolina, and they started looking at the notion of post-traumatic growth, and they started using things, themes like perceived benefits, positive aspects, or transformation of trauma. And then they settled on the term post-traumatic growth. So that is their term, not mine. But what is it? Well, it is a capacity for growth. And when Lisa talked about this, the capacity for our brain and neurogenesis and reconnecting pathways and all this, but it is a capacity for growth emerging from the survival experience. And we can see this with TBI, certainly with the work I do with addiction dependency. It is a positive psychological change, and this is key. This is key. It only comes about when people engage with the struggle. It doesn't happen independently. Just like you don't get stronger biceps by thinking about it. You have to engage the system. So it is engaging with the struggle, the life crisis, and these extreme events that bring this capacity forward and this ability. So Tedeschi and Calhoun, this is the 5 domains. So think about it in your own life. When you've been through a struggle, something challenging or whatever, and you work through, sometimes you can see one of these or more of these where you have a greater appreciation of life. Sometimes your priorities change as a result of that. Your relationships become warmer, more intimate. And I'll just stop there for a second. One of the doctors who resuscitated me, actually, I know him. And our kids, and we know each other. And a few months after my event, I saw him socially, and he said to me, hey, you look great. How are you doing? And I felt comfortable saying to him, physically, I think I'm doing well. But I said, Bruce, I think I have brain damage. And he laughed and he said, I've never resuscitated anybody for that long who is A, alive, and B, talking to me and saying, I think I have brain damage. And he said to me, you're an athlete. And when athletes have an athletic injury, they have to rehab it. He said, you have to rehab your brain. You have to spend time doing that. And so he and I were closer than ever before because of all this. But that's just one idea of a intimate relationship that got stronger as a result of this. You get a sense of personal strength, like, oh my Lord, I got through this. I'm working through this. So you understand your strength, spiritual development, and the capacity for new possibilities. I cannot tell you how many times I have literally done hundreds of interviews with people, and not overnight. This happens over time. It is a process people go through. But so many times, things that happen to people took them away from the life they had before. But yet it opened up a door that they said, had I not gone through this, I would never have gone into this profession that I always wanted to do, but stopped. So it opens up those new possibilities. So when we look at how we bring forth this notion of resilience, grit, and post-traumatic growth, we not only look at why, but how do people do this? And Lisa talked about a lot of the how, but I want to talk about, how do people get over, or nobody gets over anything? How do people work through and grow from brain injuries or whatever? I want to talk about the how from the perspective of post-traumatic growth. So I don't like the term rehab or rehabilitation. I think it's extremely short-sighted. I don't think it at all covers the capacity of what people can do. So I just made up a new word, and I have the word metahabilitation. I copyrighted that word because I know through my own experience what I was able to achieve. And it's all about the productive, positive, what can you do ideology. So meta meaning Greek, above and beyond, moving beyond, habilitation, restoration. I think we can metahabilitate, we can go above and beyond, we can surpass and exceed baseline. And people do it all the time. All the time people do it. You've done it. You might not have recognized it in yourself, but you do it. And we have to recognize we have this capacity. We have amazing internal systems to do this. Let me just bring about the whole notion of our immune system. What are we doing with COVID-19? Our immune system says, I can do this. I just need to be prompted. So these issues prompt us to do this. And so metahabilitation, the work I did with my doctoral work, and afterwards I created stages of this process, things that can predict or facilitate this, and characteristics that I noted with metahab survivors. And here's the thing, you've got to have a game plan. You got to have a game plan. I don't care if you're doing the Super Bowl. I don't care if you're going back to school. I don't care if you're organizing how you're putting together your semester. You got to have a game plan. And once you get that game plan together and you start incorporating all the people that are part of that. So let's just look at we just had the Super Bowl. That game plan came together. It wasn't just a head coach. As Lisa said, everybody came together. It was the defensive coordinator, the offensive coordinator. It was the kicking guy. It was all those people. You got to have a game plan. Here's the Mikal-Flynn metahabilitation model, and there are stages people go through. And again, please look at, there are stages. This is a process. You got to recognize how you go through this. First, you got to get through the acute stuff. You got to just get through the bad stuff. You got to stay alive. Then people make the choice. I'm ready to say yes to life. And everybody I've ever talked to who has moved forward can tell you almost the day, the time, the moment where they made the choice to say, I'm going to move forward. Once they do that, you get into all sorts of treatments, whether they're complementary, traditional, or whatever. And that's when the team comes together. People advocate for your care. People come together. They're looking things up. They're getting people together. What do you need to move forward? Then there's a time at stage 4. You're tired, been through a lot. Sometimes you got to just sit down for a while and think, what did this all mean? Because people who do well after trauma find meaning. And this is the time that they start to find meaning. They accept, they have adaptations for now. Stage 5, they get back into life some way, somehow they move forward. And stage 6 is metahab. It's taking on the future. It's like once you get that idea in your head, you can you get stuff that goes on, you go, I got this. I got this. It may knock you back, but you can continue to move forward. So if you're looking at acquired brain injuries and traumatic brain injuries, you have to start looking at what influences the progression forward. can be time from the injury on. As Lisa said, you got to get on this like right away. And people go, oh no, we want the brain to rest. No, no, you want to be moving. The severity of the injury makes a difference. The community aspects, how healthy psychologically they are, what was the satisfaction of their life prior to this, what about the injury, and again, comorbid conditions or pre-existing conditions like depression. Got to tell you, people go through this, it's depressing. It's depressing. And I tell people, I expect you to be depressed, but that is not a psychological illness. It is a part of the process, as is anxiety. And then also, what are the person's beliefs about their ability to change after the trauma? So this is a busy slide. I'm going to go through this, but this is the work I did with a whole list of conditions. It's really cool. I give this to people and I go, check off what you have, because that's what we're going to start working with. And they'll always say, you want me to check off what I don't have? I go, no, what am I going to do with you don't have? I don't want to work with that. I want to work with what you have. There's also characteristics, check off what you have. And so what I did was I distilled down, I sent out a huge survey and I had people look at, when you deal with people who have gone through trauma, what are the things from those lists that you see the most? Well, 97% of people say they always see their resilience. 92% they always see hope. And you never, ever take hope away from somebody. Oh, I'm so messed up. Yes, you are. But you know what? You gotta hold on to that sliver of hope. That's the name of my podcast, actually, Sliver of Hope. They have gratitude, they adapted, they had positive relationships, they were able to have personal insights. Look at what I have. Look at what I have to use for, and they make productive decisions about their care. Control, control, control. They're taking control and setting goals. They have a spiritual life to them. They took time to figure things out. So I took two studies, one from 2015 and one from 2013. They actually came out of Ireland. And I put side by side the top 10 things I just talked about and some of these meta-analysis talking about what relates to doing well. And so if you look at these things on the left side are some of the things I came up with, and the things on the right side came up from these meta-analysis. So again, employment, so growth is related to employment. Get people back to doing something. Employment could be volunteering too, but just something. The people who had longer education or had higher degree actually did better. There's subjective beliefs about change post-injury. They believed they could get better, and that transformed into action. The relationships they had prior to and those brought forward after made a difference in supporting and advocating for their care. Age at the time of the event makes a difference. And again, how much longer do we have after the injury? You want to get going again right away. And again, levels of depression and recognizing those. If people are too depressed, you've got to deal with that first. Then you move into. So again, using post-traumatic growth inventory, they used all these things to measure this. They saw that post-traumatic growth was associated with greater use of adaptive coping strategies. So you talk to people about strategizing things, and that brought about lower levels of distress and how they believed they could get better in the aftermath. So looking about things to ponder. So surviving and thriving. People do this. People have done this. It is a possibility. Neurogenesis, plasticity, and working with the brain to heal. There are situations where people have had, because of, for example, seizure disorders, a hemispherectomy, where they've taken the entire hemisphere out of a person's brain. And yet that brain goes, oh, shoot, you know what I got to do? I got to figure this all out. And it does, but it takes time. You partner with people to do this and establish goals, and you bring everybody on board to be moving forward. Again, recovery is not a static event. It's a continuum and it's a process, and you make some goals and then you may slide back when you try new things, but then you move forward. Okay, it is not a reinstitution of somebody's life. Here's a big thing I always talk about. People, how do we get over this? How do we get over this? I go, there is no getting over it. People don't get over this. They use it. They use it. They use their power to move forward. And you recognize that grieving and depression is a part of the process. So well-being is a skill. I just highlighted that. When I especially work with people in, you know, first responders and people going through all this kind of stuff, I go, you have to be as mentally fit as you are physically fit to do some of the jobs you're doing. Mental training brings about happiness, creativity, and productivity. So it is a skill. Coping mechanisms are skill sets that we bring forward. So again, these are not psychiatric problems. I'm so glad that Lisa brought up the notion of people get these diagnoses and are put on these meds. They're not crazy people. These are not crazy things. They are rehab issues. They are survival issues. And we have to focus on those. Number one, as soon and as often you can give people control, they do better. I talked, when I wrote my book, and I'll show you about that, I talked to people from University of Colorado who do work on neurobiology, stress resilience and control. And Dr. Steve Mayer, the work that he has done on control, that says even when people have a perception of control, they do better. Even when they're perceiving they're controlling some of the situation, they do better. So when we have these problems with depression, identity crisis, all this stuff, you can get, and, you know, all these people go, you want to solve those problems. We want a deeper understanding of the survivor's experience, the TBI, all that, you know, addiction dependency experience. What brings about this? Self-efficacy. Back to Bandura. People's abilities, you work with them to say, you can do this. What do you have? What do we have to work with? They play a major role in their determination. It is not my survivor journey. It is their survivor journey. It is what they want to do. And my role is to help them get there. So again, one of the big things that I've highlighted here, one of the biggest sources of discord doesn't involve people know themselves, but it is the distortion between their self-beliefs and capacity. Because how many times do people say, well, I don't know if you can do that. Well, I don't know if we're going to be able to do that. Well, I don't know if what is that? Who knows what people can do? And when I talked to Dr. Tedeki and with my book, he said, you know, we have all been humbled being in the presence of people who were told they couldn't and did, and what that means. So again, control, control, control. Exercising influence over exerting their influence over things. Are we misunderstanding illness and injury and actually addiction dependency? Are we misunderstanding this as something bad? These are not endpoints. These are beginning points to new lives. And we have to recognize that they, in fact, can generate unbelievable ways of coping and dealing with and growth and development opportunities. So giving meaning to these adversities, being optimistic and feeling that you have an ability to give back after this is huge. We need a more balanced approach to trauma. It is, again, bouncing back to better. It is not the fall. It is the rise. We need to focus on the rise, not the downfall. So here's the work that I do. This is all I did. My first book, Turning Tragedy into Triumph, Rehabilitation, a Contemporary Model of Rehabilitation, is out. in April of this year. I'm very proud to say my second book, so excited about it, is Anatomy of a Survivor, Building Resilience, Grit, and Growth After Trauma. And it is, you can actually pre-order it now. You can just put it in there, and it is through Simon & Schuster. And it is a book that really takes the metahabilitation concept and really promotes that. And I go into the whole neurobiology, the genetics of this, all that kind of stuff that goes with it. But last word on really quick, the whole notion of addiction dependency, which I really was supposed to be talking about even more, but it all fits in. I just want to say this. I worked a lot with addicts and alcoholics. And my word to them is that there is an immense dichotomy with addiction dependency, in that I say to them, you are the strongest people I have ever come across, because nobody has done to themselves what you've done to yourselves. And not only are you alive, but you are moving forward. And when you start dealing with people who are affected by addiction dependency, and you start promoting how strong they are, how resilient they are, how they've adapted and adjusted and can move forward, that is a game changer for them. Because I'm gonna tell you, nobody talks to them like that. They just talk about bad, what's wrong, what they haven't done, instead of shifting it over and saying, no, you are so strong. You are so capable. And that's the thing that I did. Sometimes within themselves, they don't understand that strength in themselves. And when I give them that little list of characteristics and facilitating conditions, I'll work with them over several months. And so many times they'll fill it out the beginning, and as we work together, they check off more. And I said, see, I taught you nothing. That's in you. That is already in you. And I'm just having you uncover what is in you, and you can take that forward, and you need to use that. You need to use that. So that's what I bring forward. It is hope, but there is so much research around hope, optimism, the ability to give back, all that in rehabilitation. So I hope when you work with people, you start to focus on what they have versus what they don't have. So I'll stop there. Got a few minutes for questions, and boom, done.
Yay. Any questions or comments? I saw Alina had a couple of comments. Thank you. She loves your term, and she likes the shifting of the language and the messages. It is very powerful.
Yeah, I really love what you're saying. It's very refreshing.
Mm-hmm.
And oftentimes we have to be reminded of this, because we can get caught up in our day-to-day ways of doing the therapy. And just your information that you're sharing gives us an open portal to give us more information and perspective on how we can really approach the population of students, VAs.
Mm-hmm.
I just really appreciate your presentation, and I took a picture of your book.
Oh, good.
Oh, yeah.
See, it's a good thing I put that up there.
If you are all into, so I'm trying to get more Instagram followers than the Kardashians. So if you're on Instagram, follow me at dr.jmf, or you can go to my website, drjmf.com, goes to that. But and also if you listen to podcasts, my podcast series is called Sliver of Hope. Stories of survival and growth. And they do just, people tell their story, and you start hearing these stories and you just hear it over and over. And I get so frustrated and almost angry. Like, people ask me, why are you doing this? I said, because people want this.
Mm-hmm.
Yeah.
People say to me, how come this is the first time we've heard of this? How come this is the first time that and just also if you go to my website and you reach out to me, I'll give you some articles I've written about. You can experience vicarious and secondary traumatization survivors. So
Mhm.
people who work in the field, people who deal with people like this all the time, they in fact can also experience post-traumatic growth, resilience, and resilience as a direct response to the work they do. So they get more out of it. And so it becomes less exhausting for them, and they start to recognize what they're getting out of this.
Oh, can you in the chat just put down your podcast information and that way I down.
And anybody that you would like to share this to, please feel free to share. So
Yeah. And I do work at a campus, a college where there's VA resources. So I'll share with my my colleagues as well.
well, and that's the other thing I was going to talk with Lisa too, because we have so many vets here, and
Mhm.
talk about the different different kinds of interactions you can have. I've been working with them, and she needs to be a part of that.
Mhm. Well, we've talked about it a little bit, and there's been some discussion. At one point, I proposed some kind of service for vets who are on campus, and and it could be this campus, every campus, where they can get whatever kind of connections to what they need, and then if they need some stuff to help them be a student again, we can work with those cognitive processes that can help them be a student again, and of course counseling and things like that. But there's I think we're all trying to figure out like what we can provide at the university and what the VA provides, and acceptance of it, and not making it something that is like they're afraid to access because they don't want to. There is a lot of the VA student information or student loans that they give, or the student the tuition payment is based on being a student in good standing. And so there's some fear of like, if I say that I have any trouble with this, that maybe I'm not going to get, funding and things like that. So I'm still hoping for that. I'm working for that. But right now it's kind of, it'll probably be after the pandemic, hopefully.
Yeah, and so I just work with a lot of community colleges, especially with disabled students in the VA, and we have organizations. I don't know if you've reached out to community colleges, but we have thousands of students that could really benefit from this presentation. And maybe what I'll do, if you're open, I can connect you with, well, I'll reach out to my organization to see if they're interested in your presentation, and perhaps they can reach out to you and you can present to all the educators that work in the community college throughout California. There's 118 campuses.
Oh, sure. No, that'd be great.
Yeah.
We
Okay.
could expand this a little bit too, to be more specific about some of the issues.
Fast through this.
Mhm.
Yeah. Yeah, the other thing too is I think that's so important about this is when Lisa brought this up, and I thought she was so good about this, was the lack of reporting. And sometimes when I tell people, look you need to report this because you can get better. That's the other thing. People don't know they can get better. And you go, if you report it and we can deal with that, you can get better. And really quick, I decided 2 years after my event to get my brain really working good again, because I already was a nurse practitioner. So I thought, oh, I'll go back to school. That's it. I'll go back to school and get my master's. So I lived close to Sac State. So I went to Sac State. I went to the School of Nursing, and the woman was in the front, the administrative assistant. And I said, look, this is my name. I had this event. I don't know how well I'll do, but I'd like to try going back to school. And just as I was saying that, the woman who is a division chair of nursing walked by, and she said, who are you? And I said, Joyce Mikal-Flynn. She goes, what happened? I said, well, I had this swimming event, and it was at this big public event. And she said, I was there that day. I saw. So she became my mentor, Dr. Robin Nelson, and was on my dissertation committee. So she has seen me all the way through. So I always tell people, you've got to tell the truth, because then people can help you, because you can improve. So
Absolutely. Absolutely. There was a couple of comments. Yeah, the whole reporting thing, most of the time they only report it after it has happened repeatedly and gotten bad enough to cause work problems. Yeah. And we see that. And the great news is that there are ways to work on these things. There are ways to improve them. And so you just have to acknowledge it, identify it, ask for the help, and then it can be improved. So it's just finding the right connection sometimes and being able to ask for help. Absolutely. Thank you all for coming.
Right.
And we're happy to go on the road. Sure, we'll go on the road. We went to Boston one time.
Lisa and I, hey, Lisa's got her own survival story too. I told mine, but Lisa's got her own trauma survival story. That's
I'm a cancer survivor. So, you know, I had to acknowledge the fact that something was not right. And then I got diagnosed and then I had to fight like heck. So yeah, I'm here. I got my hair back, which is good. And I feel pretty good. But anyways, thank you all so much for coming. And yes, absolutely. And hopefully this is a great day. I'm glad this is being put on.
All right.
Thank you. Bye-bye.
Thank you. Thank you. Thank you.
Bye.
Bye.